Hello, everyone. My name is Sherry Causable, and welcome to the Introduction to Polysomnography, a Clinician's Guide. Um, my background, just to be brief here, I am a registered respiratory therapist. I'm a certified respiratory educator. I'm a registered polysomnography technologist, and I have a certification in clinical sleep health and clinical hypnotherapy. So the objectives of this webinar today, basically, I want to go over what is normal sleep, what's polysomnography, different types of polysomnography, different types of levels of testing, sleep management options, sleep disorders and indications for testing, and then as well some study discussion. So polysomnography, what is polysomnography? Polysomnography is a multi-parameter sleep study that either confirms or rules out sleep disorders, which includes routine polysomnography. So it's basically a standard test to confirm or rule out pretty much any sleep disorder. And routine polysomnography, like levels 1 and 2, are basically the same setup except for the video and technician. So I'll go over that a little bit in a little bit. There's specialized polysomnography. So basically, if we're looking at seizures and determining the right type of ventilation for treatment, so that's beyond CPAP. Nocturnal polysomnography with the CPAP titration, the split night, which is part diagnostic, part therapeutic. So it's traditional polysom or a routine one with a CPAP titration. And then, of course, multiple sleep latency testing or MSLT, which just measures daytime sleepiness to help diagnose narcolepsy and determine the severity of sleep apnea. We'll usually do these the morning after someone has done a sleep study. So they come into sleep lab for level 1, and then they would stay for the MSLT for the rest of that day. Basically looking at how long it takes for them to fall asleep. Tells us the level of sleepiness, and then if they meet the criteria for narcolepsy or just severe hypersomnolence due to sleep apnea or other sleep disorders. And then, of course, maintenance of wakefulness test, or MWT, which basically measures a person's ability to stay awake in a dark room. That one can be challenging for a lot of people just in general, but we have specific criteria where we'll see sleep disorders in these certain circumstances. So levels of polysomnography. So if you look at a level 1 study, basically this is always done in the sleep lab, and it is used to determine one of 88 different sleep disorders or more. So you can have more than one sleep disorder, and people often do. This level 1 monitors brain waves, oxygen levels, heart rate, breathing, eye movements, and leg movements. And in an effort to determine, in essence, is the person moving through the sleep stages and the sleep cycles like we expect them to? And if they're not, what is waking them up? This is why we gear them up in every level. So all the different ways that we know that sleep can be disturbed, whether it's through movements or breathing and such, which I'll get into in a little bit. The level 1 or level 2 study is done at home or in a sleep lab in some circumstances, and it's very similar to level 1, but there's no technician present or video. And then finally, level 3, which is a home sleep apnea test or an HSAT, is conducted using a portable device, and we're specifically looking at diagnosing determining obstructive sleep apnea. Used on its own does not diagnose obstructive sleep apnea. It also has to be in conjunction with clinical indication as well, or clinical correlation. It monitors specifically breathing activity, and so it's a chest belt and sometimes an abdomen belt, depending on the type of HSAT, oxygen levels, and heart rate. This is another one I wanted to bring a special mention to. Pulse oximetry. We used to call it a level 4. We no longer do it here in Canada because of its lack of specificity. We're specifically using it only to determine baseline oxygen levels at night. But However, when we do look at these, sometimes when we're testing people who have COPD, like a chronic lung condition, or they have a heart condition, or they have a neuromuscular, we'll look at the baseline, and sometimes the baseline will be good, but the desaturation event index, or the how many times per hour on average their oxygen levels drop, is elevated, and elevated is anything over 5. And when we look at the DEI and, this drops in oxygen saturation, when we look at the severity of this, we're looking at the depth of desaturation and the frequency of the index, or the severity, the high level of numbers happening per hour. And these drops in oxygen saturations are often linked to breathing interruptions. And it can be those caused by sleep apnea, but of course, we can't, it's not enough, not specific enough to say exactly why the oxygen levels are dropping. We just know. And so often we'll look at some clinical correlation, and we look at whether this person's a candidate for a level 1 study in the sleep lab, so that we can determine more of whether it's an airway issue, is an obstructive sleep apnea, or if there's something else going on. And finally, we can use this desaturation event index to triage people through higher level testing as needed here in Canada. So why do we study people? The reason why we study people is to see how their brain is moving through sleep. Sleep is really important in how it's structured, and its structure lies in its components, and the components of sleep are stages. So stage N1, it's a transitional sleep. It's non-REM sleep. So you can see stage N1, N2, and 3, those are non-REM types of sleep. So 2 different types of sleep, non-REM and REM. N1 being our transitional. So in each sleep cycle of 90 to 110 minutes, we've got about 1 to 5 minutes of that would be stage 1 sleep, which is specifically a state shift of consciousness. Stage N2 is about 50% of the sleep cycle. Again, this is in adults, and in different ages of adults, we'll see different proportions of stage N2, which are going to be more appropriate. The younger you are, the less of the stage 2, the more stage 3, and the older you are, the more stage 2 and the less of stage 3. Stage 2 we see is most helpful in sorting useful memories for easy retrieval. And stage N3 is really good for deep sleep, like stage 3 is deep sleep. It's really good for body repair and memory consolidation. We see that stage N3 typically will make up about 20% of the total cycle. So REM sleep itself has approximately 20 to 25% of the total sleep cycle, and we see it in 2 phases, phasic and tonic. And if you look at movies where they're trying to show someone's, dreaming something really profound, they'll have them move their eyeballs underneath their eyelids, and that's where they're trying to show phasic REM, or the crazy dreams. And then the parts of the brain that are associating with learning are activated in this particular sleep stage. So this goes back to taking these components and putting them into what we call a sleep structure. So we take all of these sleep stages and we put them into these cycles, and they go stage 1, stage 2, stage 3, REM. It's like a dance, 1, 2, 3, REM, 1, 2, 3, REM, typically. Sometimes people can, when they come out of REM from the first cycle, they don't necessarily come back up to wake, and then N1 again. So they skip N1 altogether because they don't need a transition, and they go specifically to stage 2, or sometimes back into REM, depending on what's happened before in their sleep. So typically, like a normal sleep period of 7 to 9 hours, we see about 5 cycles of these of sleep happening. And in each cycle, we have that beautiful rhythm happening. If for whatever reason we get interrupted in one of these sleep stages, it's kind of like playing Monopoly. If you get interrupted, you don't just pick up where you left off. You go back to the beginning. So let's say you're in this beautiful deep stage 3 sleep and you get woken up by a noise outside, or your room's too hot, or there's a light or something on, and your brain gets woken up. So you get back into wake sleep. Then you have to transition back down into 1 again in the stage 2. So if you think about that, if you have a sleep disorder such as sleep apnea, where your airway is waking you up so many times per hour, or you have restless legs and your legs are waking you up so many times per hour, or your environment's not optimal, you can see how the phases or each cycle will be interrupted enough that the progression and how each cycle is built on each other just doesn't happen. So we normally spend our first course of the night, like the first third or so of the night, is stage N3 sleep. So it's mostly deeper sleep. The second part of the night, we have more of a concentration of REM. So if you get woken up several times in the first part of the night, your brain still needs to get that N3, and it's going to keep trying to get it, and that REM is going to be pushed off more and more. And then if you don't stay in bed long enough, you're not getting that last part of the night that you need so much, that REM sleep. And then in the morning, even though you've had so many hours of sleep, and maybe the total sleep time hasn't been changed, but the structure was altered, so you won't feel as rested. So this is, when we put it all together here, this is what a normal sleep architecture looks like. We have here the stage wake, we have stage REM here, we have stage N2, or sorry, N1, N2, and then we go to N3, and then of course it goes up to REM. And this particular person, they didn't wake up at all, so of course they didn't transition into 1, they went straight down into stage 2, then into stage 3, and then they transitioned back up into 2 for a little bit before they decided to go into stage REM. And you can see here in the first half of the night, the stage 3 sleep is decreasing in duration, and the second half of the night, it's increasing in REM. And this is a normal sleep architecture. So if you look at this particular study, this is exactly what sleep apnea looks like. And you can see this particular person, there's very little going on when you look at the brain activity happening up here. So look at the top 2 leads here. This is the eye. So right eye, left eye, central EEG and frontal. And then we've got a chin, and then we've got ECG, and then we've got legs, leg 1, leg 2. This is a thermistor, so it's a way of measuring the flow of air, and it's usually in front of the mouth or the nose or both, depending on the sleep lab. A lot of times we'll have a nasal pressure transducer as well. Looks like a nasal cannula, but in this situation there isn't. There's just a thermistor. Thoracic belt, abdominal belt, both effort belts, and oxygen levels here, and then we have the chin. So in this particular situation, you can see all these obstructive apneas happening. This person's making the effort, but there's no flow happening until boom, airway pops open, and they take a few little breaths, and then they do the same thing again. This from here all the way over to here is a 30-second window. So this person in 30 seconds is doing 1, 2, 3, 4, 5, 6, 7, 8 obstructive apneas in a 30-second window. It's a lot. It's a lot. So it would be an average then of about 16 events a minute. It's quite severe, actually. So when we look at the impact on this particular person, you can see the oxygen levels being impacted. But you can see here, there's really not a lot going on. There's maybe a little bit of flattening and maybe a little bit of lightening of sleep, maybe some arousals in here, but very, very little actually. This person looks like they've been doing this a long time. And what's happening is they're just coming up into perhaps a lighter stage of sleep before they get a couple of breaths and fall back into some deeper sleep, and then they do it again. So not a lot happening with this person in general. This is just an artifact, just a head movement is what it looks like, because you can see the two go together. And then this is quite out of range, and it looks like a movement sort of thing. You can see this sort of thing. This is just an electrode that went all wonky on us. So it was just a movement that happened there, probably as a result of this person falling back asleep after this particular apnea. Okay. This here is awake. So this is wake brain activity. You can see this is the eyes here. And you see in general here, this is very, steady eyes until you hit about here. And you can see a little waxing and waning, waxing and waning. And this is what we call the slow rolling eye movement happening. And this is typical of starting into thinking about into stage 1 sleep. This is alpha in here. So this is wake activity. You can see how it gets quite quiet here. So the person's thinking about the sleep. It's just the brain's calming down, basically. And then we've got the chin activity here. This is just indicated that the stage he's in wakes. This person's awake. It's a 30-second snapshot of time. Another 30-second snapshot of time. The epoch is stage 1 sleep. You can see here the stage 1. And then you see the slow rolling eye. The left eye was cut off in this particular image. However, you can see that the eyes are rolling. Nice little rolling happening here. And then we've got the central leads. See how quiet everything is. A little bit of alpha intrusion here. And that's quite common. We'll see some alpha happening in stage 1. But for the most part, it's nice and quiet. It's a slower frequency for the most part. And the chin's a little bit quieter as well. Stage 2, you can see that chin is flattened out even more. You can see you've got some what we call these K complexes happening. We've got what we call spindles that are happening here and here and here, here and here. And these are characteristic of stage 2 sleep. You can see how quiet the eyes are. They're nice and straight. And yeah, nice flat chin. Not completely flat, but flatter. This is stage 3 sleep. So we used to have a stage 4 sleep where there was a proportion of how much of these big delta waves were present. And if there was more than, I think it was 30%, it's been a while now. But I think it was more than 30% of the epoch was delta, then it was stage 4. But now we just call it all stage 4. If there's 30% or more, then it's just stage 3. So you can see here the eyes. You can see how much this delta activity, these deep frequencies of waves are moving into the eye electrodes as well. It's really cool actually to see that. These sometimes we get a little bit of artifact that happens here too. These may even have a cardiac sort of origin to them. It's hard to say unless I need the rest of the level 1, because all I'm getting here is just the brain activity in this particular one. But this is a lot of growth hormone happening here. This is REM. So you can see how quiet. All of a sudden we can go from this to this. And that's literally how it happens. And the eyes, everything gets quiet, and then the eyes start with this beautiful open, close, eyelids not open and closed, but the eyelids moving underneath, up and down and side to side. And that's how they make these beautiful patterns. This activity here is just a nice low mixed frequency, and it's very characteristic of REM. You can see how flat the chin is. It's completely flat at this point. It's at 0, indicating that we have no muscle tone and we're in fact in REM. This is phasic REM, meaning the eyes are moving. So theories of sleep. These are some of my favorite parts of sleep. And I mean, we still don't know everything about sleep, but in general, what I remember sitting in the sleep lab years ago and reading about this, and the idea is that that non-REM was about sorting everything for quick, easy, retrievable access. So think of your desk or even a library like this young woman here. And everyone comes in all day and they're taking out books and putting them in different places. The librarian at the end of the day takes all those books and sorts them all. So the next day, everyone can find the books accordingly, quick, easy, retrievable. That's what sleep in non-REM does for your memories. So in general, the next day, whatever you have learned or heard or adapted from your environment, you're going to be able to use that effectively and efficiently the next day. It lends to our survival. And the dreams accordingly, if you can think about a library, they're boring. They are thinking dreams. There's not much going on there. And in general, a lot of times people think that they're thinking in these sleep states. If you wake them up, they think they're thinking. So they may have felt that they were just sort of drifting off when in fact they were in stage 2 or stage 3. In REM, you know you were dreaming. These dreams are saving the world, crazy dreams. This is where we get brain repair and we process emotions and we consolidate memory. And we're saving the world and becoming, you know, all the childhood fantasies of all the things we wanted. So, you know, we know that that long-term memory and consolidation happens in non-REM 3 and REM sleep. And we also know that those waves that we see in the stage 3 sleep, those big, deep, large amplitude waves, they can cause a wash or a wave of CSF or cerebrospinal fluid over the brain in these sleep stages. Now, the reason why it's interesting, and we know that there's things that get washed through the cerebrospinal fluid from waste from the brain, and things that can gum it up, so to speak, to keep those connections from happening. But also we understand that growth hormone is one of the large hormones, or the prominent hormones that is excreted in stage 3 sleep. So perhaps this CSF fluid is, you know, spritzing your brain with some nice cleaning fluid. Who knows? We still don't fully understand all these processes. So sleep hygiene. So when we look at all of this sleep structure and how the brain works and how important it is to get it, it's really important to set yourself up for success. So sleep hygiene is the way to do it. It's the very first thing we look at when you get a sleep consult. And the doctor says, you say you're tired, the doctor should be saying, so what is your sleep hygiene? What are you doing? You know, how do you start your day in the morning? What are you eating? How much are you moving? What's your stress management like? What are you doing during the day? And what are you doing at night? They both affect each other. The timing, the choices, the duration, they all influence your body clock and your pressure to sleep. So what's the role of sleep, diet, and exercise? So of course, like depending on the individual, if we're in tune to our bodies, we know what works best for us. And what works for me is not necessarily going to work for the next person. So what we're looking at is trying to control digestion, stress management, activity level, and light exposure. So essentially that's the gist of it, and that can happen in many different forms. So let's look at light exposure, for example. So if you look at light exposure, that's one of the biggest influencers of our master circadian clock at night. So some people, depending on their work, like when I'm working on my computer like this later in the evening, I'll use a blue light screen so that the type of light coming from the computer isn't affecting me as much. Now, if I had issues with insomnia or any sort of sleep disorders issues, I shouldn't be using any forms of light 2 hours before bed, because it's preventing my brain from making the hormones that pressure me to sleep, and will perpetuate an insomnia issue, or an insomnia tendency at the very least. So, in essence, if you look at the two sort of options you have of how you set yourself up in sleep hygiene sort of perspective: bright light, stress, strenuous activity, and I'm going to add in there eating, like things like sugar or caffeine. They increase cortisol. And of course, that gives you more of a, okay, wake up your body. And then that in turn ends up in a awakened type brain frequencies, such as beta. So calm activity, on the other hand, we have low light, calm activity, positive emotions. Those end up in secreting a serotonin and dopamine increase. And then, of course, when we cut the light out, we've got now melatonin instead of cortisol. And that leads to alpha brain activities. Now, alpha is really important because alpha is the doorway to the subconscious mind and to sleep. So what is normal sleep? After all of that, what is normal sleep? When you think about all the variabilities of, age and gender and personal preferences and where you live in the world, these are these biopsychophysiological factors that we all sort of experience. And, all these influences can make a real big impact on what is considered normal. So if you look at all those factors, the one thing that is influenced the most by all of them is duration. So on the basis of that, the ASM came up with a consensus for the sleep amount that's necessary to support optimal health. And this is specifically for adults. Children are a totally different story. But they decided that 7 to 9 hours is the magic numbers that support optimal health. So how do you build a routine then? You build it based on your preferences and suggestibility, and just be consistent about it. Understand what works best for you. Do you relate to calming influences through stretching? Are you more physical in that need? And then, or, do you need like a mindset tool such as meditation or breath work or something like that, where you're going to be able to start calming the mind down? And essentially, don't get stuck on rules. There's so many different techniques out there. Use what works best for you. Yours is going to be unique. Find what works for you, stick with it, and adjust as you need to. And, understanding what's happening with your body in the moment, and understanding how these tools are affecting you, and making little adjustments, triaging, taking your temperature as you go, of, how successful are you and how much further do you have to go? And just in general, it's okay to have a bad night. Everybody has a bad night. I teach this and I have bad nights because we're human. But the key is to not perpetuate it by thinking it's a real issue. So what is your body trying to tell you when you're awake? Did you exercise too much too late? Did you eat the wrong things? Or did you eat too close to bed for you in this particular part of the world? The Italians would tell you it's totally fine to have something to eat at night and then go to bed. And they do just fine. But in your situation where you live and what is normal for you, what might be something that is sabotaging you? So If you were to talk to a sleep doctor, if you get yourself a consult because you have some sleep issues, your doctor has sent a sleep consult to a sleep medicine physician. And the very first thing they're going to look at is, are you optimizing your sleep hygiene? Are you crawling into bed with a chocolate bar? Or are you leaving your TV on all night with the lights going? Or is your bedroom too hot or too cold? How are you controlling everything? How are you exercising? When are you doing it? For how long? What sort of stress management techniques do you have? Any sort of counseling or something that you maybe want to add in there? Doing whatever works. And then the next part, after they've looked at all of that to make sure that there isn't some big glaring factor that's been staring you in the face this whole time and you didn't know, they will look at your chief complaint. So what is it? Do you feel fatigued in the morning? Do you feel unrestored no matter how hours you sleep? Are you not being able to get to sleep? Can you not stay asleep? And they look at, well, what's your goal? How do you want to change it? We never expect to tell people what they should or shouldn't be expecting from it. We know that where they're at is not where they want to be. And having that clearly defined, and then having the goal clearly defined in the patient's or the client's words and perspective is so, so important. We never assume that we know what the right answer is for them, because again, everyone's sleep is different and unique to them. They also look at their medical history. Are there things in their medical history like higher blood pressure, uncontrolled blood glucose levels? Do they have low iron levels? Things like that that can exacerbate, the difficulties in getting to sleep in general, or staying asleep, affecting the other body organs that contribute to pressures to sleep or not. And, medications maybe, those quite often I'd see in the sleep lab people with depression. They were given an antidepressant and they were told, take it at night because you'll have less side effects that way. But what they don't understand is some of these antidepressants are REM suppressants. So people don't have REM sleep until very early in the morning. And maybe they'll get one, maybe 2 cycles of REM, and that's it. And they wonder why they're not functioning. So it's about timing. It's about understanding the drugs that you're on. It's about understanding the conditions that you have and optimizing what's within your control. The other one is provincial guidelines. Provincial guidelines, so that is referencing the Canadian system here. So let's say you go into see the sleep doctor and he says, you know what, you need to have a level 1 study. I want to bring you back into the lab here. And you're like, you know what, I can't do it. I got a dog at home. I got nobody to stay with my dog. Or, you know what, I can't sleep in other places. Or, I have family and or I've got something's going on. There's always something. And we hear this all the time. And in those cases, the docs can often look at home sleep apnea tests. Now, that's all works as long as there isn't a comorbid condition or other extra factor. Because if there looks like there's anything outside of sleep apnea, or they are dealing with other major health conditions such as diabetes or metabolic syndromes just in general, which we see quite often with sleep apnea, then we can't do those home sleep tests. So then, because the provincial guidelines are telling us that this person may be complex and we do need that higher level study for a definitive diagnosis. Finally, we've got looking at these biopsychophysiological factors before determining needs. So if I were to tell a sleep physician here how an Italian has their sleep, and when they eat and what they do, they'd think we were crazy. But if you were to switch that and tell an Italian sleep doctor how we do it, they'd think you're crazy too. And different parts of the world, things work differently. And sometimes it's just the geography that makes all the difference. Sometimes it's a cultural factor where it's really deeply ingrained in that culture to do things in specific ways. And so really considering all those factors before determining what changes need to be made. So we look at studying people, we're looking at determining whether they may have a sleep disorder. And the International Classification of Sleep Disorders 3 is put together by the American Academy of Sleep Medicine. It's basically comes up with 6 categories. So the first one is insomnia disorders. The second, sleep-related breathing disorders, central disorders of hypersomnolence, circadian rhythm, sleep-wake disorders, parasomnias, and sleep-related movement disorders. So the first one, insomnia disorder, is probably the most common one that people know of out there. And it can be one or both of, a complaint of either trouble at starting or getting to sleep or maintaining sleep. And it has to be also associated with daytime consequences and not attributable to people sabotaging themselves with a poor sleep environment or not going to bed when they're supposed to be doing so. This disorder includes both acute or chronic forms. Chronic, the insomnia has to persist for at least 3 months and a frequency of at least 3 times a week. Acute is just the persistence is less than 3 months. And of course, like I said earlier, we've all suffered from insomnia at some point, and it's just a natural thing. How we view it and how we manage stressors in our lives and our sleep hygiene determines whether it is acute or chronic. We know that advanced age, female gender, and people in a lower socioeconomic status or medical or psychiatric illness are at higher risk for acute and chronic models. Sleep-related breathing disorders. So there's 4 groups basically here. The most common one is obstructive sleep apnea, and then of course central sleep apnea. Several different causes when we're looking at central sleep apnea, and some of them, sometimes when we look at that and the hypothesis is, it could be medications, or it could be that this person has got several comorbid factors and they've got some poor heart function, and sometimes those are factors in it. But we find with the central sleep apnea, they can be tricky to treat, and we find that on an individual basis sometimes. It can be quite challenging that it may look like it's one thing, but when we go to treat it, it doesn't react the same. So interesting in that way to treat it for PAP therapy. Sleep-related hypoventilation disorders, of course, and then sleep-related hypoxemia disorders. Then, of course, we've got central disorders of hypersomnolence. So to have this, you have to have at least 3 months of daily sleepiness. And we can see this as a daytime sleep episodes or irrepressible needs to sleep. So like severe pressure to sleep. And of course, there's 2 main groups here. They're primary, where we see the narcolepsy, the idiopathic folks, and then the Klein-Levin syndrome. And the secondary, we see hypersomnia that's caused by a medical or a psychiatric disorder. So it's secondary to these medical or psychiatric things. And then or secondary to a drug or a substance, or of course, insufficient sleep syndrome. Circadian rhythm, sleep-wake disorders. These ones we see quite often in healthcare, people that work shift work, and that we see it with jet lag. We see it with, people that are, delayed in going to bed. They can't get to sleep until quite late and then wake up, later in the morning. We usually see those in teenagers. And then advanced sleep-wake phase disorder, those are our morning larks or our senior folks for the most part. Some of the toughest ones to treat are these irregular sleep-wake rhythm disorders and the non-24-hour sleep-wake rhythm disorders. So basically, we're a 24-hour clock, but on the outside, but on the inside, we're not. We're a little bit more than that. And of course, we keep shifting or jet lagging every day as a result. This is, of course, linked to poor light exposure, and people that deal with blindness will notice this as well. Parasomnias, I love the parasomnias. They're just fascinating. It's basically abnormal behaviors or experiences while sleeping. We group them into either REM or non-REM sleep. In the REM group, we have recurrent isolated sleep paralysis, where you basically wake up and you can't move, nightmare disorder, and REM behavior disorder, or RBD. Non-REM, we see sleep terrors, sleepwalking, confusional arousals, sleep-related eating disorders, and sleep-related, and then of course, they're all on its own is sleep-related hallucinations, exploding head syndrome. And we actually don't see people's heads explode. It just, these are folks that as they're falling asleep or waking up, they'll hear a loud sound like an explosion, and sometimes a flash of light. It's quite distressing, actually. Sleep enuresis, which is bedwetting. This does not include the little kids. We're looking at kids over the age of 5, I believe. Sexsomnia, so that one is people who find themselves in sex acts, whether through themselves or sometimes their bed partner, while they're actually in sleep. And cataphrenia. And then if you look at, this is the next one here, sleep-related movement disorders. The interesting part with the movement disorders is they're abnormal movements, but they are not abnormal behaviors as such. They're behaviors, but they're more of like a rhythmic type thing. So restless leg syndrome, you see it with genetics, pregnancy, nutrient deficiencies like iron, and certain medical conditions. And it's just this discomfort in the legs. It usually is better in the morning and increases throughout the day. And people will find this irrepressible need to move their legs as they're falling asleep. Periodic limb movement disorder it's repetitive. We refer to it often as river dancing at times, because it is, you can set your clock to it. It occurs every 20 to 40 seconds, and you can see it as a foot flexion or a jerk. It's very rhythmic. Sleep-related bruxism, or jaw grinding and grinding and gritting of the teeth. And usually we can see it while people are awake as well. I often see this with people with sleep apnea that's not treated, because what they're technically trying to do when they grit their bottom jaw is to open up the airway. And then the interesting piece with this one, of course, is REM sleep behavior disorder, or RBD, is also referred to as a sleep-related movement disorder. And this is the behavior that they're talking about. So what do we expect? What do we expect when we treat people in these sleep disorders? What do we expect to improve? These are all the different things that we're looking at. We're looking at mitigating accidents, improving sleep efficiency, managing GI symptoms. When you look at sleep, if you are in a fight flight, you're not resting and digesting, then you have symptoms of the gut that are you have inflammation basically happening in the gut. And then, of course, the symptoms that come along with that: excessive sleepiness and alertness. We want to improve our total sleep time and our quality, realign our circadian rhythm to the outside clock, improve mental health and quality of life. And then, of course, work performance, how important is that? Seriously, you want to love what you do and do what you love. So if you look at, how we are affected as respiratory therapists in the healthcare system, there's a lot going on that affects our ability to downshift. We spend most of our day in adrenaline and cortisol, and we're either thinking, planning, projecting, coming up with alternative solutions for patients and situations. And it's go, go, go for the most part, whether you work in community health services or in acute care. But it's typically adrenaline, cortisol filled. And I know in community health services, I think one of the challenging things that I find is working with palliative realm, where you're trying to find the best solutions for some unique and challenging situations, and that can be just as stressful. So if your system is used to being in this fight flight all day, it's really difficult to switch that off for nighttime. We also don't have that cue from the external clock for the artificial light and chaotic activity. We are just wired in every way with the thoughts that are going through our head and the lights that we're exposed to be awake, and not just awake, but reactive. And also, fatigue is considered normal, and not just normal, but it's expected in a lot of cases. We find it equaling a dedication and excellence culture. And I think we're getting better at this piece here. I'm seeing some shifts with doctors, and not so much with RT folk as much, but with the Canadian Medical Association here, we're seeing doctors doing more lifestyle change to find more work-life balance here. And sometimes too, even though we're the best trained, we do everything right, sometimes our clients don't do well, or our patients, they don't do well. And that type of stress can be very difficult to deal with, and especially when you're trying to fall asleep at night. So what do we do when we're trying to reduce the stress and bring on the sleep? And, just like this little guy here, we're getting in ourselves, we're into a state where we feel safe, and we can, shut down and not worry about what's happening around with the rest of the world. So it's practice, just like, babies. We have, if you have kids, or people who have kids, they have these routines where they just set up these expectations for these little guys that go, go, go all day. And then, the lights calm and everything else calms. And even the voices get even quieter, just like I do with my hypno. And the expectancy, the intention is known pretty quickly, and the shift starts to happen. As adults, we can use a lot of different things. We can use apps, we can use music, we can use mindset techniques, we can use breath work. The mindful breath work, the 4-7-8, and the diaphragmatic breathing, the big ones. So what do all these things do? All these things, what they do is they shift you this downshift. We're shifting from a beta state, which is this more alert sort of concentrating, thinking, planning state, into alpha state, which is the gateway to subconscious mind. We see it in meditation, and we see it when people are feeling super calm. So the interesting thing about healthcare workers in particular is when you are going all day, you're exhausted. When you may be exhausted, but you've got a task at hand, and you kind of push through. And then when we're super tired and we finally get that chance to sleep, we just crash. We don't even alpha, we know we go through alpha. Well, maybe we don't. You will after this, but you pass through alpha very quickly. So you go from beta into theta, which is theta is your sleep. And it's a crash through. It's kind of a push through because you're so exhausted. Now, once you get that first 90 to 110 minutes, we have this wake after sleep onset time period that happens. And we look at this in sleep studies and we see what is the time of wake after sleep onset? Like, how long does it take for you to wake up again? And we kind of look to see how many times you do that, how often you do it, and what happens there. How long are you there for? Now, if you're not practiced at shifting down like you would in a car, like gearing down, you don't know how to gear back down again in the middle of the night, because now you don't have that pressure to sleep, that exhaustion that you did at the very first part of the night. And now you've got just enough sleep under your belt to not push you through, unless you understand how to trigger your own alpha state. So a person trained in this, like people with meditation and mindfulness, breath work, all those things, yoga, they can initiate sleep quite quickly because they're practiced at doing this, shifting that state. How do we make this mental switch? I went over this a little bit already: meditation, visualization, breath work, gentle stretching, listening to calming music or audiobooks, or even podcasts, soft lighting, reading apps, so many different things, chatting with your friend or your spouse or colleague at the end of the day to decompress and just leave it all out, so you don't have to bring that in your brain with you into your pillow. So it's about working it all out before you climb into that bed, setting yourself up for success, and knowing who you are. The reading, the visualization, the listening to calming stuff, that's for people who are quite read between the lines. They're looking for more information all the time. They're thinkers. Whereas the people that are the doers, the movers, the make it happen, the physical people, they're the ones that do really, really well with breath work and gentle stretching. And of course, all of us can do for some soft lighting. So what does the American Academy of Sleep Medicine suggest in these situations? They always have great opinions on these things, and I actually love referring to their suggestions. We use them as our guideline up here in Canada. We also have the Canadian Sleep Society as well, but the AASM is one of our benchmarks, and especially with their ICSD-3, where they've got their diagnoses, and then when you've got a diagnosis, you have a pretty good idea of how you're going to suggest to physicians what to follow for treatment. So the ASM suggests a 30 to 60 minute buffer before bed. Now, what is that? That's your mental switch over time. So that's your, reading or stretching or listening to your podcast or listening to music or something. It basically gives you that decompression time so you can downshift. We don't often get this buffer, especially in healthcare, because we're working that 12-hour shift. You get home and you just want to eat quick and get to bed so that you can get that night's sleep in. The reality is that most people will fall asleep much quicker than 30 to 60 minutes using suggested techniques above. Most people think that they're going to lay there forever, but they do a few little of these techniques, the breath work, the mindfulness, that they're falling asleep pretty quick. So this is another thing that the ASM looks at, and this is a cognitive behavioral therapy approach. It's basically about reassociating the bed in a positive and repetitive way. So what we often do in this day and age is we put TVs in our rooms with lights and sounds and computers. We bring our work in there. And so what happens is our subconscious mind or our body starts associating the bed with these tasks instead of the expectation of sleep. So it's kind of like setting the mood for your system in general. How are you setting the mood for yourself? Are you doing this wakeful, let's go, this is work time sort of mood for your body and for your mind? And if so, it's going to give you a negative experience. And if it gives you a negative experience, then you're going to expect that for the next time. This is what we get with cyclical insomnia. These are like basically, you know, we reassociate the bed in positive, repetitive ways, and we get new positive associations. So this is where we have the foundations for cognitive behavioral therapy for insomnia, the CBTI, and then the brief behavioral treatment for insomnia, the BBTI. So typically we see the CBTI is the most effective. The BBTI is the one we see more often because it's more accessible and more cost effective for people. So how do we manage fatigue? So we can manage fatigue in two ways. We can, the first one being better sleep. So how do we get better sleep? In general, the very first thing we look at with getting better sleep is making sure that circadian rhythm is aligned. Your master circadian clock, your central clock in the middle of your brain, is the one that is pressuring you with light or with light to secrete a cortisol and serotonin, and everything feels really good, and you're awake and you're focused and you're doing what you need to do to survive. When the light shuts off and it no longer gets sent to that central computer in the middle of the brain from the eyes, then we're now creating melatonin. The melatonin is a pressure to sleep. And when it is secreted in the body, it tells the other body clocks that are in the body to also slow down, relax, lower metabolism, lower function, and do the rest and digest mode. So if you want to get this positive feedback effect, we're looking at managing your light. And then you can also use things like hypnotics and sedatives to basically improve your total sleep time. So, you know, sometimes there's not as much you can do with the light exposure that you'd like to do. So we can add in that melatonin. So the type of melatonin that you use is really, really key. So if you are a person that wakes up a lot during the middle of the night, you can get to sleep okay, but you can't stay asleep, then we would look at sustained release, and we would look at lower levels. So something similar to what your brain makes, like about 1 milligram. And then that would stay in your system as a slow release for the night. And it would help you with that middle of the night thing, manages to set that circadian rhythm again. If you have trouble getting to sleep, then you would go with a regular dose, but a little higher of a dose, because it gives you that little oomph to get into sleep. But with that, then you would also be looking at doing some of these cognitive behavioral therapy techniques and optimizing your sleep hygiene on top of it. So in effect, when you have higher doses of melatonin, you have more of a sedative effect, and lower doses just realign the circadian rhythms. So the other way of managing fatigue is stimulants. So timing is everything. We use modafinil for persistent fatigue. We see this often with people with the non-24-hour, the sleep-wake phase conditions, and we see it with people with narcolepsy. It can be quite effective to help people stay alert and awake for the day, can have some tougher effects on the gut. Caffeine in small amounts for the first half of the shift is the best way to do things. You can get used to caffeine. And what we find is that if you keep the caffeine in small amounts and keep it to the first half of the shift, it's way less likely to impact your sleep for the rest while you're trying to sleep during the day. And exercising, like getting rid of um, the stress, sometimes moving the body, knowing what works best for you for that stress management. Are you moving the body in the way that works for you to release that stress? Are you overdoing it and creating so much adrenaline in your system? Now it's like having 10 cups of coffee going. The other one is eye movement. So if you're having difficulty staying awake, moving your eyes, they tell you this when you're first learning how to drive a car. So timing with all these things is everything. You can do a heavy workout, but don't do it at night. Do it in the morning. It's going to help you with stimulating you for the rest of the day and feeling really good. Modafinil, again, you're going to talk to your doctor about, how much and what you're taking, and they often have to kind of titrate that one. The caffeine, using that to help you stay awake while you're on your shift, but in the way that supports your sleep as well. So pharmacotherapy, basically, it's really dependent. They're going to give you all different kinds of options that you could use, and depending on your particular situation, once you've been studied. And often we'll put this pharmacotherapy in place first, so that while we're working to get the CBTI, and CBTI can be at least 8 weeks, depending on the program, to start to take effect. And it can continue to be effectful, but it can take months thereafter. And when someone's exhausted, they need something to help them for the short term until the CBTI now becomes their new magic pill. And then, of course, patient preference, treatment goal, and cost. Oh my gosh, cost is a big thing. So this is the clinical practice guideline for insomnia that the American Academy of Sleep Medicine put out. We basically go with the very first one. We recommend that clinicians use a multi-component, that's the key word there, multi-component CBTI for the treatment of chronic insomnia disorder in adults. Now, notice they said chronic only, not the acute. So one of these components that they will use is called sleep restriction therapy. We don't see this very often, but it can be quite useful. Basically, it enhances the drive to sleep and consolidates it. So what we do is, when you're talking to the patient about how many hours they think they sleep, if they're telling you, I'm up all night, I don't really sleep, you can say, well, how many hours do you think you sleep? And let's say they say, I'm in bed for maybe 10 hours, but I sleep maybe 5. So what we would tell them to do for the first night is not to get into bed until they get into bed at a certain time, and they only stay in bed for that 5 hours. And then they have to get up the next day. And depending on the schedule and how the doctor sets this, we'll add in time gradually, day after day after day, until we get to the point where we're at the minimal amount of sleep required to feel restored. It can take a little bit of time, especially if someone thinks they're only sleeping a few hours at night. But we know that they're sleeping longer. So what this does is, if you're tired enough, the idea is that when we restrict that sleep, you're going to sleep straight through. And then we keep that consistency, that less wake up time. We don't use this with people in safety critical occupations and mood disorders and seizures for obvious reasons. Relaxation therapy. So again, this is based on what your preferences is. We use either somatic tension reduction or cognitive arousal reduction. One's using the mind, one's relating to the body. Just knowing what's your suggestibility, what is your preference. Sometimes you mix the two. And mindfulness therapies. Meditation format is the typical one, but we can combine this with stimulus control, sleep restriction, and sleep hygiene. And of course, the emphasis being on the observer. This is about bringing us back into present moment, which brings you back into an alpha state, which is the gateway to sleep. That's what meditation generally encompasses. And just awareness, this mind-body connection on a moment-to-moment basis. It's hard to ruminate and think and plan when you are paying more attention to awareness on a moment-to-moment basis. So finally, summary. So there's many factors exist to determine the need and the appropriate pathway for diagnosis and treatment of reported sleep challenges. You can understand why sleep doctors and clinical sleep health practitioners like myself work together and have these loops that we work together to run people through a diagnostic pathway and then see how they respond to treatment and come back sometimes for retesting and then other times going to different treatment pathways. It's a bit of a trial and error sometimes, but for the most part, it's a journey that usually finds us helping people back to the goal that they envision for their sleep. And again, one size doesn't fit all. These are individuals that are going to need individual sleep plans. And listening to your client and your patient, you take the extensive history before you consider any testing. It's going to determine the right test. And then, of course, you get the right test, then you're going to get the right treatment, and then you're going to get optimal efficacy. And treatment is two-pronged. So support those healthy behaviors and the mindset, and also treat your imbalances and symptoms. It's basically treating this person as a whole. So we've got the sleep hygiene piece, and then we've got the cognitive behavioral therapy and the pharmacotherapy. And these are my references. And thank you very much for spending this time with me today. I appreciate it.